Hi there, grad students. I have 16 test questions for you on Obsessive Compulsive Disorder. Ready? Let's learn psych fast. Question 1. Which neurotransmitter is found to be low in OCD? Is it A, glutamate, B, serotonin, C, GABA, or D, acetylcholine? The answer is C, GABA. So in folks dealing with OCD, it turns out there's a link between glutamate and our habit control. Glutamate levels were up while GABA levels took a dip in the ACC. Remember the ACC? That's the anterior cingulate cortex. These changes in the brain chemicals hint that they might have a role in pushing these compulsive behaviors front and center. Question 2. Obsessive compulsive disorder is a disorder that remains under investigation as to its actual neurophysiology. What tricyclic antidepressant is approved by the Food and Drug Administration to treat OCD? Is it A, clomipramine, B, imipramine, C, neurotriptyline, or D, amitriptyline? The answer is A, clomipramine. Now, clomipramine got that official nod for treating OCD, but guess what? The others, imipramine, neurotriptyline, and amitriptyline, did not make the cut for OCD treatment approval. Question 3. A patient is admitted to the unit with OCD. What drug has been found to be effective for treating OCD? A, fluvoxamine, B, phenelzine, C, dizipramine, or D, amitriptyline? The answer is fluvoxamine. Guess what? Fluvoxamine, it's the superhero for treating OCD. It falls into the SSRI gangs. These SRIs aren't just about OCD. They're the go-to for dealing with depression, panic attacks, bulimia, and more. Now, phenelzine is the go-to hero for depression that's a bit stubborn. Dizipramine and amitriptyline, they're part of the tricyclic antidepressant crew tackling depression, especially if it brings anxiety or sleep issues to the party. Question 4. What is the recommended duration for cognitive behavioral therapy in the treatment of OCD? Is it A, a few weeks, B, 6 months, C, 1 year, or D, continued on as an as-needed basis? The answer is C, 1 year. When we're talking about rewiring the brain in the context of OCD, CBT is the star of the show. But it's not a quick fix, it's a journey. The recommended duration of CBT in OCD treatment is often around 1 year. It's like giving the brain enough time to learn new patterns and responses, gradually breaking free from the cycle of obsessions and compulsions. While some individuals might experience significant improvement in 6 months, the general recommendation is to continue CBT for a longer duration to solidify the gains and address any lingering challenges. Question 5. Which class of medications may be considered as an alternative for the treatment of resistant OCD? Is it A, mood stabilizers, B, anticonvulsants, C, MAOIs, or D, anxiolytics? The answer is MAOIs, monoamine oxidase inhibitors. So when OCD seems to be putting up a tough fight against the usual suspects like the SSRIs, MAOIs step onto the stage. They're like the backup quarterbacks coming in when the main players need a break. In case of treatment-resistant OCD, where the standard medications haven't quite done the trick, MAOIs might be considered to bring a different strategy to the field. Now let's look at the other options for that test question. A was mood stabilizers. While mood stabilizers, they might have a role in certain conditions, they're not typically the first choice for addressing treatment-resistant OCD. Option B was anticonvulsants. That's wrong. While anticonvulsants are often considered in mood disorders and epilepsy, their role is not in the treatment of resistant OCD. Again, think MAOIs. Option D was anxiolytic, which was also incorrect. Anxiolytics, of course, is a benzodiazepine. They might provide temporary relief for anxiety symptoms, but aren't the primary choice for addressing treatment-resistant OCD. So, in that playbook of treatment-resistant OCD, MAOIs are like the strategic move made when the usual game plan needs a shake-up to break the cycle of obsessions and compulsions. Let's take a little break. I have a little study aid summary for you of the questions we've done thus far. So just as a reminder, the number one is CBT. Treatment should be greater than a year. Is CBT plus or minus meds. And what meds you're going to use? Number two would be SSRIs, the fluoxamine. And then number three, up to the stage, would be the TCAs. And don't forget, there's those other meds from SNRI groups and MAOIs. What are the parts of the brain that you want to associate OCD with? That anterior cruciate cortex, the ACC. Glutamate's up, GABA levels are down. Question 6. Which of the following ablative psychosurgical interventions may be used for the management of OCD? Is it A, anterior cingulotomy, B, capsulotomy, C, limbic leucotomy, D, subcaudate tracheotomy, or E, all of the above? The answer is E, any of them. Pick all of them. So if we're talking about treating OCD in any kind of out with the old, in with the new type of style, there are some traditional surgical moves like these otomies. So pick one of these for those resistant folks on your test. Question 7. What percentage of patients with OCD who have undergone a cingulotomy have positive 5-year outcomes? Is it A, 20%, B, 45%, or C, 70%? The answer is C, 70%. So here's a scoop on the modern treatment scene of cingulotomy. It's like the hero for almost 70% of folks with OCD and around 75% battling with major depression. And guess what? Anterior capsulotomy, paired up with a radiosurgery, it is scored a 70% response rate after a cool 5 years. Talk about some positive vibes for these treatments. Question 8. True or false? The inferior thalamic peduncle is the target for neuromodulation psychosurgery for OCD. True or false? The answer is true. So when it comes to OCD, it's like a brain circuit misbehaving. Blame it on the cortical striatal thalamic gang. There's this thing called the inferior thalamic peduncle, and it's the link between the thalamus and the orbital frontal cortex. Turns out tweaking this connection is a game changer for treating OCD and even tackling the blues. Question 9. Which of the following is required for the diagnosis of OCD? A, presence of obsessions and compulsions. B, they must recognize their obsessional thoughts are not true. C, symptoms must be present for greater than 6 months. Or D, symptoms must be time-consuming or causing significant distress or impairment. The answer is D. So individuals with OCD have varying levels of insight regarding their symptoms. They may recognize their obsession compulsions to be definitely not true, or they may be convinced they are true. This can be specified as good, fair insight, poor insight, or absent insight or delusional beliefs. A is incorrect, as it's presence or obsessions or compulsions or both. B, incorrect. Obsessions is defined as thoughts, urges, images that are recurrent, intrusive, undesired, and cause distress or anxiety. C, wrong. Compulsions, that's the repetitive behaviors, mental rituals, and that the individual feels driven to perform, often in response to obsessions aimed at preventing or reducing anxiety and stress. And D, that's incorrect. Time consuming. It takes over an hour a day, or it causes significant distress or impairment, like social or in occupational settings. Question 10. Which of the following is a predictor of good prognosis in OCD? A, presence of precipitating event. B, onset of symptoms during childhood. C, coexisting major depressive disorder. Or D, bizarre compulsions. The answer is A, presence of precipitating event. When it comes to predicting how things will go with OCD, having a triggering event is like a good sign. But watch out, because the other stuff on the list, like poor social or occupational adjustments and symptoms that stick out or stick around, they're not great indicators. So a silver lining might be having something that sets things off in the first place. Question 11. Adolescents with OCD are most likely to have which of the following? A. Acute stress disorder. B. ADHD. C. Body dysmorphic disorder. Or D. Major depressive disorder. The answer is C. Body dysmorphic disorder. OCD isn't just one thing. It's like a group of related disorders. We're talking about body dysmorphic disorder, hoarding disorder, trichotillomania, and skin-picking disorders. All are part of the OCD family. But wait, choices A, B, and D might show up too, but they're not exactly in the OCD club. Question 12. In pediatric patients with OCD who participated in appropriate treatment, which of the following best represents the percentage of patients who recover by early adulthood? Is it A, 10%, B, 40%, C, 60%, or D, 80%? The answer is B, 40%. So for kids dealing with this disorder, here's the deal. Around 40% get a break from it by the time they hit early adulthood. For some, it sticks around, but with steady treatment, they can still rock normal functioning. Now, about 5% of the little champs don't respond to treatment, and that's when things get a little bit tough for them. Question 13. Which brain region is often implicated in pathophysiology of OCD? A, the amygdala, B, hippocampus, C, basal ganglia, or D, prefrontal cortex? The answer is C, basal ganglia. When it comes to the brain dance of OCD, the spotlight often falls on the basal ganglia. This region is like the conductor in the symphony of obsessive compulsive disorder. The basal ganglia is involved in the regulation of movements and behaviors. And when things get a little haywire, it can contribute to the development of OCD symptoms. It's like the control center where the obsessions and compulsions might be getting a little bit too much airtime. So let's look at the other answers that were incorrect. A, amygdala. The amygdala is more like the emotional wizard of the brain. When emotions play a role in OCD, the core mischief tends to be happening in the basal ganglia, though. B, hippocampus, wrong. The hippocampus is crucial for memory, but it's not the primary player in the OCD tango. D, prefrontal cortex. The prefrontal cortex, that's the brain's executive. But in OCD, it often takes cues from the basal ganglia. It's like the prefrontal cortex is getting a lot of signals from the basal ganglia, influencing the behaviors seen in OCD. So when we're talking about the geography of the brain involved in OCD, think basal ganglia as the area where the orchestra might be playing a little bit too loudly, leading to the intricate dance of obsessions and compulsions. Question 14. Which type of psychotherapy has demonstrated efficacy in the treatment of OCD? A, psychodynamic therapy, B, dialectic behavior therapy, DBT, C, exposure and response prevention, ERP, or D, interpersonal therapy? The answer is C, exposure and response prevention therapy. Now, when it comes to tackling OCD through the power of therapy, exposure and response prevention is the hero of the story. ERP is like the strategic general in a battle against obsessions and compulsions. It involves exposing individuals to anxiety-inducing stimuli exposures and preventing the associated rituals or responses, the response prevention. It's essentially rewiring the brain's response to obsessive thoughts. It's like saying, hey, brain, let's face these fears head on without doing the usual rituals. While psychodynamic therapy has its merits, it may not be as targeted and specific in addressing the behavioral patterns of OCD as ERP can. DBT, it's fantastic for certain conditions like borderline personality disorder, but not for OCD. Interpersonal therapy focuses on relationships and interpersonal issues, but not the core rituals and behaviors seen in OCD. So in the world of OCD therapy, think ERP as a coach guiding individuals through the challenging but transformative journey of facing fears and rewriting the brain's response to the script. Question 15. What is the role of atypical antipsychotics in OCD treatment? Is it A, first-line treatment obsessions, B, augmentation strategy for partial responders, C, primary treatment for compulsions, or D, preferred option for pediatric patients? The answer is B, augmentation strategy for partial responders. So in the grand orchestra of treating OCD, atypical antipsychotics play the role of supporting actors. When someone is given it their all if with a standard treatment like SSRIs, but it's only making partial progress, atypical antipsychotics step up as the backup dancers. They augment the treatment, adding an extra punch to the performance and helping those who fully haven't responded to standard medications. Now let's look at the other options that were incorrect and understand why. A was first-line treatment for obsessions. Atypical antipsychotics aren't usually the go-to for tackling obsessions head-on. Their strength lies in complementing the primary treatments. C was primary treatment for compulsions. While atypical antipsychotics might have a role in certain cases, they're not typically the first choice for addressing compulsions directly. D, preferred option for pediatric patients. Atypical antipsychotics may be considered for certain cases, but their use in the pediatric population often involves careful consideration of risk and benefits. So when it comes to the intricate dance of OCD treatment, atypical antipsychotics are like the backup dancers, adding the extra flair for individuals who need a bit more support in their journey to symptom relief. Question 16. Which comorbid condition is commonly associated with OCD? Is it A, bipolar disorder, B, social anxiety disorder, C, ADHD, or D, borderline personality disorder? The answer is B, social anxiety disorder. When it comes to companions on the OCD journey, social anxiety disorder often decides to tag along. It's like having two buddies with overlapping concerns. Individuals with OCD might not only be grappling with the obsessions and compulsions, but might also find themselves wrestling with the social anxiety, the fear of judgment or negative evaluation in social situations. It's like a double feature, and those two conditions sometimes go hand in hand. While individuals with OCD might experience mood fluctuations, it's not as commonly associated with bipolar disorder or borderline personality disorder. DHD and OCD can coexist, but the closer connection in terms of shared concerns often lies with OCD and social anxiety disorder. So in the world of OCD and its entourage of comorbid conditions, social anxiety disorder often become a familiar face, adding another layer to the complexity of the individual's experience. All right, I included another study aid summary for you that you can review, and hopefully this will help you greatly in your test. So with ablative surgery options, just think those otomies. You'll get a 70% success rate with these patients then. And then with adolescents with OCD, their best friends is BDD. But for adults, their best friend will be SAD. And of course, you have to know the DSM-5 diagnostic criteria for OCD, which is the presence of obsessions and compulsions, or both, must be time-consuming, taken greater than an hour, or cause clinically significant distress in an area of their life. It cannot be attributed to a medical diagnosis or substance abuse, and not better explained by another medical condition. And of course, the treatment of choice is CBT, but that's the umbrella term. The more specific therapy is ERP. And let's just rejoice that 40% of patients will be OCD-free when they become an adult. All right, thanks for studying with me. I hope this really helped, and please share this with a classmate so more people can be successful. And go ahead and just click on this video next. I believe YouTube selected this one for you, thinking it'd be the best. Thanks. Good luck.